So let's move on to the next hemolytic anemia, which is paroxysmal nocturnal hemoglobinuria. So here it is the only acquired intracorpuscular defect, right? So till now we had seen about all the inherited diseases in intracorpuscular defects, membrane, enzyme, and the hemoglobinopathies. Next we are going to the acquired kind of intracorpuscular defect. The only disease under this was the PNH, which is paroxysmal nocturnal hemoglobinuria. So here the defect is going to be in a gene called as PIGA. So PIGA gene is defective. So PIGA gene usually encodes for GPI anchors. So GPI anchors are usually anchors which fit certain proteins into the membrane. So when this GPI proteins are not, anchors are going to be defective, the proteins which are going to be inserted normally are not going to be inserted. So because of that, they are going to develop disease. So one such GPI anchored protein is CD55 and CD59. So CD55 is the decay accelerating factor, DAF. So this is going to inhibit normally the C3. So normally the complement C3 is going to be inhibited by this DAF, and CD59 MERL is going to inhibit the MAC complex, which is the final product of the complement activation, right? So normally the CD55 and 59 is going to prevent the excess activation of complement and complement related damage. So when this PIGA gene is defective in the PNH, it is going to result in GPA anchor deficiency, right? So when GPA anchors are not there, the GPA anchor proteins are also going to be deficient. So CD55 and the CD59 deficiency is going to cause excess activation of this complements. So there is no inhibition, so complement activation is going to happen uncontrollably. So when complement activation is there, it can affect the all cell lineages. RBCs can be affected, WBCs can be affected, platelets can be affected. So in RBCs, it is going to cause paroxysmal nocturnal hemoglobinuria. In WBCs, it is going to cause loss of the WBCs resulting in infections. So platelets again will be affected, leading to bleeding. So as such, there is going to be a pancytopenia kind of a picture, okay, pancytopenia. So why is this given the name nocturnal? Usually the patients have the symptoms of this hemoglobinuria during night. So in PNH, there is going to be hemoglobinuria in the night time. Why so? Because during night time or even sleep or exercise also, there is going to be a decrease in the pH resulting in acidosis. And this acidosis can trigger this defect. So acidosis can result in hemoglobinuria. So that is the reason why these patients have hemoglobinuria at night time. And the released hemoglobin here, it is going to combine with the nitric oxide. So along with this nitric oxide, it is going to combine and form thrombus. So multiple thrombus is also a feature of this PNH. So this thrombus is going to result in multiple sites. So DVT you can have, stroke episodes you can have, and mainly Budd-Chiari syndrome. So Budd-Chiari syndrome is hepatic vein thrombosis, right? So already while speaking about WBCs, I mentioned. So here Budd-Chiari syndrome is not that common. So whenever you see Budd-Chiari syndrome and hepatic causes are ruled out, you'll have to think about certain other diseases, especially PNH. One thing will be the antiphospholipid antibody syndrome, APLA, and then PCV, which is polycythemia vera. So all these three things are again prone for developing into this Budd-Chiari syndrome. Okay. So this PNH is as such related with aplastic anemia, then MDS, and also acute myeloid leukemia. So this is going to be a series like this. So all of these conditions are going to be interrelated. So being a stem cell defect, it can result in AML finally also. Okay. And the defect here, right? So here actually it is a intravascular hemolysis again. So intravascular hemolysis, it is both microangiopathic hemolytic anemia and PNH. So how do you diagnose PNH? So flow cytometry is the investigation of choice here. So and especially in flow cytometry, you'll have to use this FLAIR. So FLAIR stands for fluorescent aerolysin. So this fluorescent aerolysin is going to test for this GPA anchors. So with flow cytometry, you can use CD55 or CD59. So both of us going to be coming negative in this because it is not going to be anchored, right? So on RBCs, platelets, or WBCs, you can check for in any of the three cells. You'll have to check for this markers, and it is going to be negative. And FLAIR again is going to be a GPA anchored protein only. Okay. So this FLAIR is going to be the investigation of choice for this. So since PNH is induced under acidotic conditions, you can use other tests wherein acidosis is there. So Ham's acidified serum test or a sucrose lysis test. So here again, you can induce the hemolysis and test for the hemolysis. And if you see the lab score, which is the leukocyte alkaline phosphatase score, here again it is going to be decreased. Okay, so this is very important. Only in CML we had read till now that lab score was decreased, right? So lab score is going to be decreased in PNH as well, because lab itself is a GPI anchored protein. Okay, this alkaline phosphatase is a GPI anchored protein. So when GPI anchored protein is not going to be there in PNH, obviously lab score is going to be decreased here. So the treatment for this is going to be either you can suppress the complement activation with a drug called as eculizumab. Eculizumab is going to be inhibiting the C5 convertase. So C5 convertase is going to be inhibited by this drug. So you can give this eculizumab drug. Otherwise, if it is a stem cell defect, right, so you will have to do a bone marrow transplantation only. Okay.